Paroxysmal Nocturnal Hemoglobinuria, PNH. So PNH is a acquired blood disease caused by somatic mutation in the phosphatidylinositol glycan A, PIGA gene. So PIGA gene is responsible for encoding an enzyme called phosphatidylinositol glycan anchor biosynthesis class A protein. And this enzyme is involved in the synthesis of the GPI anchor, which attached to the certain protein to the cell membrane. This GPI anchor proteins are involved in the various cellular processes, including cell signaling, cell adhesion, and immune response. Mutation of PIGA gene can lead to a rare genetic disorder, which the title of this video is called Paroxysmal Nocturnal Hemoglobinuria. It's characterized by the abnormal breakdown of a red blood cell and other symptoms. And PNH mutant cell lack all GPI anchor protein, which include two essential complement regulatory protein, which are CD55, which is a complement decay accelerating factor, and CD59, which is an inhibitor of the complement membrane attack complex. So in the PNH red blood cell, we don't have these protein that is needed for the GPI to anchor. So PNH is a rare, acquired clonal disorder of hematopoietic stem cell that is characterized by hemolysis, bone marrow failure, and thrombosis. And it occurs in about 1 to 5 cases per million worldwide. Although very small clonal population of the PNH cells of approximately 0.001% to 0.005% can be detected in most healthy individuals. PNH hematopoietic cells have no intrinsic growth advantages and do not clonally expand under any normal condition. And slightly larger PNH clone of about 0.02% to 0.03% can occur in approximately 1% of the healthy individual. However, more significant clonal expansion of the PNH cell do not occur in the absence of any pathology. In contrast, PNH clones are prevalent in patients with immune-mediated bone marrow failure. About 50% of the individuals with acquired aplastic anemia develop PNH clone, where the PNH cell escaped the immune attack on the hematopoietic cell, dominating the bone marrow. In terms of the PNH clone in the setting of MDS and MPN as well, beyond aplastic anemia. So PNH clone can emerge in patients diagnosed with MDS and less frequently in those patients with MPN. This underscores the occurrence that's beyond acquired aplastic anemia and highlight the differences in incidence rate across various hematological diseases. Red and blue area plot the plots to illustrate the different clinical presentation correlate with the extreme PNH clone size. So patients with the bone marrow failure who have associated PNH clones are shown in red, and the classical PNH presentation is shown in blue. So we have bigger PNH clone size in the classical PNH, and we have smaller PNH clone size in the bone marrow failure. So this leads to the connection between PNH and bone marrow failure. This is a well-established connection between the PNH and the bone marrow failure syndrome, such as MDS and aplastic anemia, which will warrant consideration for the PNH screening during the clinical evaluation. For the diagnostic core of a PNH, the flow cytometry identify deficient GPI-linked molecule in the peripheral blood cell. So this is like a foundation of the diagnostic PNH, which lie in the flow cytometry, which can detect the absence of GPI-linked molecule in a significant portion of the peripheral blood cell, neutrophils, and monocytes. For example, This is the illustration of the PNH analysis by flow. So we can see that this is the normal red cell, normal red blood cell in green. And here we have debris, and here's the aggregate. This is by using CD. So in the panel C, you can see that type 2 and type 3 clone is detected by flow based on the CD59 intensity and expression. So the more extreme loss of CD59 can be categorized as type 3, and a slight loss is categorized as type 2. And in the panel B, what we can see is full scatter cell analysis of the red blood cell, showing a good discrimination between the red blood cell singlet from the debris and aggregate by using the full scatter cell. If we look at the lower panel, a white blood cells analysis using the CD15 as a gating marker for neutrophil and CD64 as a gating marker for monocyte. You can also use other marker, and if we look at the panel E is showing a large PNH clone, PNH neutrophil clone identified by combining the flare and CD24. So we have this PNH clone detected from the neutrophil. And if we look at the panel G, you can see a large monocyte clone identified by flare and CD14. So loss of CD14 and loss of CD24 can be detected, and they are used on the routine basis, on the routine flow cytometry. And these are the references, and thank you for watching.